Good morning, all. Welcome to today's wellness seminar, which is brought to you by Jesus House Dise's Rapha's Health and Fitness Ministry. Our topic of discussion today is planning for the expected and unexpected. What we need to know now about aging, long-term care, and retirement. My name is Latunde Balarinwa, and I'm honored to be the moderator for today's seminar. Along with me today are three amazing panelists, professionals, and experts in the field who will be talking to us about today's topic. They are here today to impact knowledge, so I encourage you to grab a pen, grab a pencil, grab a paper, to note important information that may be helpful to you and your family tomorrow or in the future. A few housekeeping processes. Please be sure to share this link with your friends and family right now. Click the share button. You can download or just click the share button on YouTube right now so that your friends and family can also glean from this wonderful information that will be shared today. If you haven't subscribed to Jesus House Dise's YouTube channel, I want to encourage you to do so right now. Do not hesitate, do so because we have tons of other wonderful, amazing sermons, videos that you can enjoy and be beneficial to your spiritual growth. All right, and the last thing I'm going to ask with housekeeping is if you have any questions, if you have any comments or feedback, please, I want you to engage on the live chat. Be sure to ask those questions there and we will get your questions to our panelists today. Okay, so having said all that, we cannot start today, we cannot start this session, we cannot start this program without committing ourselves and just the discussion to the hands of the one who created us all, right? He's the one who makes everything possible, and without him, we couldn't be here today. And so I want us to welcome the maker of all things, His Highness, His presence into our seminar today. And we ask that everything that we do will please him. Amen. All right, with that settled, I do want us to join me in welcoming our very, very first panelist. She is a geriatrician, Dr. Mariana Koroma Nelson. Dr. Mariana Koroma Nelson received her medical degree from the American University of Integrative Sciences and received her Master's of Public Health from Creighton University. She completed her residency training at Howard University Hospital, where she was a chief resident and vice president of the house staff. She also completed her fellowship training in geriatric medicine, palliative medicine, and integrative medicine at George Washington University. Dr. Koroma Nelson has over 7 years experience in caring for older adults with special interest in neurocognitive disorders and healthy aging. She is board certified in family medicine, geriatric medicine, and palliative and hospice medicine. The lead physician for geriatric medicine at Virginia Hospital Center Physician Group and the medical director of Goodwin House. Dr. Koroma Nelson is a member of the American Academy of Family Physician, American Geriatric Society, American Medical Director Association, and American Academy of Hospice and Palliative Medicine. She enjoys spending time with her family, especially traveling, reading, active leisure activities like jogging. Wow, what a mouthful. Everyone, please join me in welcoming Dr. Mariana Koroma Nelson. Over to you, Dr. Koroma Nelson.
Thank you. Thank you so much. Thank you, everyone, for this opportunity. Good morning, everyone. My name is Dr. Koroma Nelson. I'll be talking about aging pertaining to how we can plan for the expected and unexpected. First of all, I would talk briefly about the statistics in aging, then normal changes with aging process, and I'll review some of the 5 M's of healthy aging as well as geriatrics. Then I would briefly talk about the different type of geriatric settings and provide resources for care provider. Next. Here we can see that we are living longer and the population is aging. From 2010 to 2020 census, we can see that people age 65 and to 75, it increased by almost 50%. And then 75 years and older increased almost to 18%. Next one. Here is the distribution of aging, the population. Currently from 2012, we can see that the majority of Americans that are 65 and older, almost 80% are white, then followed by 8.8% are Black, and then Hispanic are 7.3%, then Asian 3.8%. But the estimation for 2040 is there'll be a reduction in the white for older adults, an increase in African American older adults to 11.5%, and Hispanic would also increase drastically, almost double, while Asians also would be increased and other are increased, except for the whites. Otherwise, all of the races would have an increase. Next, please. This is briefly talking about the life expectancy after age 65. We know that the current life expectancy in the US, it's around 78 years old. So after age 65, the people that tend to live longer are actually Hispanic currently. And you will see the increase almost 20 years more totally for Hispanic, then followed by whites that are 19.3 years after age 65, then Blacks. And that same trend is followed amongst men. Still Hispanic men live longer, then followed by Caucasian whites, and then Blacks. We decrease. Men decrease drastically compared to Black women. But this estimation would change because currently we're having more people smoking, like Hispanics, second and third generation of smokers, obesity. So there might be a decrease in the life expectancy. Next one. I'm going to briefly talk about the normal changes that occur with aging. Some of the system in our gastrointestinal, which is your stomach and your colon, including once you chew food, what occurred. So there will be a decrease in saliva. That's why a lot of people complain about having dry mouth. It's not due to just medication side effect, but physiologically there are changes that occurred. And when we're trying to swallow foods, most people, especially when you're 85 and older, would have some difficulty with swallowing food, not because of just condition. Naturally, the muscles as well as the contraction is decreased, and then the people would have more complaint of reflux. Yes, you can make changes dietary, but physiologically, some of the structure, they're not as strong as they used to be. So everything aged with us. So you tend to have more heartburn, and the movement of food tend to be slower, and you would have constipation. Our kidneys function also decreases. So it's not that you have to have kidney conditions, but naturally you can't take the same dose of medicine that you would take when you're 20 versus when you're 60, because the filtration is decreased. Certain hormones that are produced or metabolized, like vitamin D, is decreased. And so all of those have to be put into consideration. Next slide. As far as our cardiovascular health, our heart, there is a decrease in our heart rate, and as well as the reflex that usually control fluctuation of our blood pressure as we age, which is the reason a lot of people would say they have dizziness when they change position suddenly, because they're just a slow process in the reflux of that. For respiratory system, the elasticity of our tissue are also decreased, and the space where you can have exchange of air also decreases in volume. So, and the space, where there's something called dead space that later increased, and that increased the risk of having pneumonia, for example, or if you're not as mobile and you're in bed and not having deep breathing exercises, you would tend to get sicker faster. As far as the urinary system, the urination, a lot of people do reports having loss of control because of the muscle contraction decreases, as well as the volume that we can hold into our bladder is decreased. So that contributes to the urinary incontinence. And for women, the hormone reduction causes changes in the urinary system, like the urethra part, where you would tend to lose control because of that reason. But sometimes supplementing with having supplementation and certain exercise helps. And for men, you would have the increase in the in the in the prostate side, and that contributes to lack of decreasing control of the urination, or either going too frequently. Next, please. For muscle, as we get older, we need to do more weight-bearing exercises because there's decreased muscle tone, which means you will have decreased strength. So it's not just walking, but doing some cardiovascular and weightlifting really helps minimize frailty. For the brain, as we all age, we do have decrease in the volume of our brain, and as well as the blood flow. So that can contribute to forgetting certain things that we've learned, not things that we learned initially like memory, but complex things that we later on learn by going to universities. Sometimes you will not lose it totally. It will take longer to do some of those tasks. And you're less likely to be able to multitask than the way you can when you're younger. So those are normal. Next, please. So a lot of the changes that occurred with aging, only 25% we can say is genetics. The rest is really what we do, the environments, what food that we eat, what type of exercise we do, and now we take care of our overall health. So a Danish study actually proved that. Next slide. Now I'll be talking about some of the 5 M's of healthy aging, as well as it's also called 5 M's of geriatrics. And the first part of it is your mind. One of the M is your mind. Your mind meaning mental health, the mental health, anxiety, for example, which is very common, about 5%, not too common as a general population among adults community settings. And the way to minimize a lot of the anxiety is trying to do balance in your life, either meditation, because a little bit of anxiety is a normal part of life in all stages of life. But when it's become excessive where you can't function, then that's a disorder. So therefore, besides just medication, there are diets that can help, like anti-inflammatory diet, healthy diet, Mediterranean diet, for example, meditation and exercise. And also talking to people can minimize and make anxiety less worrisome for people. The other, when I think of mind, and in geriatrics, when we think of mind, we also think about depression. Depression, it's about 2% in older adults. And a lot of the older men actually are more likely to commit suicide. They can be less, the older adults are 2% depressed, but when it comes to suicide, they're more likely to actually go through it. And it's usually people that are widowers and men more than women. So the way to minimize that is having the social supports like group exercises, staying connected with your community, your church, and some vitamins like vitamin B, for example, B6, have been shown to improve people's mood, as well as if you're deficient in certain, like anemic, then you'll be more likely depressed. So if that's not correctable, then you'll be feeling down, fatigue, and have all of the symptoms. The next thing that a lot of people think about when we think about older adults and mind is cognitive changes. Um, Really, cognitive changes is it's 7% of older adults, 60 and older, have dementia. And there's the most common one is Alzheimer's, of course. Um, there's more information how you can differentiate between normal cognitive changes and dementia. There are a lot of tests we can do. Your primary can do tests, screening tests in the office. But Alzheimer's.org has actually a questionnaire that you can use that determine normal versus abnormal cognitive changes that I think would be helpful. Next, please. The next part of the 5M is mobility. So mobility, it's, yes, balance, which 40% of older adults are affected by balance problem. And this can be improved by doing certain exercise, staying active, keeping your muscle mass much stronger, and strengthening exercise. So when you don't have balance, you also have increased risk of falls. And over half of people over 75 actually fall each year. And that increase the risk of morbidities as well as mortality. There are a lot of evidence-based exercises that helps with this. Tai Chi has been well studied. Dancing, like line dancing, different type of dancing, really helps minimize fall and help with balance. And gait training. The National Institute of Aging has very good exercise tool, which is free to everyone, that you can search online, that would provide different exercise program that would help minimize this. Next, please. These are just few pictures, Tai Chi and group exercise. Next, please. The next part of the 5M is medication. As I stated earlier, there are changes that occur in our kidney. The other part of our organs that are involved and system that are involved in metabolic, breaking down medication is also your liver. I didn't mention that then when I was briefly discussing some of the normal aging process. So when we get older, your metabolism and your kidney and liver changes. So the same medicine, just as I stated, that you started in your 50s, can be the same dose for a 75-year-old. It has to be a much lower dose and slowly increased. Also, because of condition, multiple medical condition, you have to think about drug interaction. Sometimes we may think we have a new condition, but it's actually one medicine that's causing another side effect, and now we're adding a third medicine. Your doctor and you should actually look into what has changed before adding a third or fourth medication. Next, please. What matters most is one of the 5M. And this, at all ages, I encourage everybody to have discussion with close family member, friends about their wishes, having a living will. It doesn't matter your age. I think it's an important discussion, because then it decreases the risk of any conflict that may occur. It doesn't put our loved one into a difficult position to make decisions if we have it written. And also appointing someone that you close to that can make objective decision, not just emotional. Next, please. Actually, the last part of the 5M is multiple morbidities, medical conditions, which I think doesn't need to be covered as a whole. If we can minimize risk, we don't have to worry about that in future. These are some of the preventative things we should focus on. Like when you encourage everyone, if you're healthy, at least see your doctor annually for blood pressure check, screening tests like cancer screening, breast cancer, colon cancer, cervical cancer, and I listed the cutoff age, and getting immunization is very helpful. Next, please. For geriatrics care setting, there are several settings where older adults can get care. In the community, at home, assisted living, and long-term care. Next. So in the community, there are options like the Villages Movement, adult day centers, home-based primary care, and the PACE. Next. So the Villages is actually a grassroots movement driven by the community. It's where neighbors actually take care of each other. It first started in Boston in like 2000, and it's based on your zip code. You can become a member for a very low fee, where they help connect you to community support, social worker, like a lot of non-medical support, and it helps with promoting socialization. If you check the village network, that would tell you more information and what villages are close to you. Adult Day Center, it's really for older adults that live with their daughters or son, like 3 generations living in the same home, where the daughter or son has to go to work. So during the day, Adult Day Center will provide medical and social care. And most of the time it's connected to a church or community. Next, please. Home-based primary care is where it's for older adults that really meets the criteria of a nursing home, but they really want to stay at home. So they would get a team, a doctor, nurse practitioner, PA, nurses, social worker that come to their home and provide care. They will also have some home health support. Next. Program of All-Inclusive Care of the Elderly, the PACE program. It's a program that's partly a day center where you go to during the day, you go to a center, and they provide medical care as well as non-medical care, like providing food, medication, physical therapy, dental care. And they also would transport you from your home to that center. Then you will then go back. The way that's this differs from day center is, let's say you are hospitalized. They have contract with different hospital where they will follow you in that hospital. And let's say you need skilled nursing and you need to go to a skilled nursing center. They will also follow you there and provide that care for you temporarily until you can return back to your home. Next. Home care is when can be provided temporarily, sometimes, well, mostly temporarily, like after a hospital stay and you're not able to really go to your doctor's office temporarily. The doctor can make a house call, and then you would have home physical fit therapy, occupational or speech therapy, or nursing care, and few hours of home health aid just to assist you until you could get back to your baseline. Next. Assisted living is different from day program as well as long-term care. It's where if you need a little bit of support to help socialization, and it's not federally regulated. It's mainly by state has their regulation. It differs from state. Next. Continued care retirement community, also known as CCRC. It's usually a place that's mainly private pay that has all levels of care. Independent living, meaning you have your own apartment, you do your own thing like it's almost your home. No one really supervises that. Then if you need help, there's an assisted living that you would transition to. And if you have more need for assistant and nursing help, then there's a long-term care or nursing home portion or memory care that you would need. And it varies. Most of them are fee for service, but depending on your needs, sometimes they can modify the coverage. Next line. Memory care assisted living is very similar to the regular assisted living. A lot of CCRC, continuing care retirement community, has one. The only difference really from regular assistant, you have cognitive impairment. So you need that supervision, where there'll be nursing staff there to assist you with ADLs to minimize safety. Next. Group homes are also options where older adults can live, and it's lower cost. And most settings, you have your own room. Few, you share room, you get medical treatment as well as socialization. And thanks. Adult foster care, it's another option that's usually temporarily, where an older adult can be cared for by a family. And a lot of them are regulations are by states, and it varies. Sheltered housing is another option that's available. They offer personal care and support as well as meal support, and the cost usually varies. Nursing home, it's typically for older adults that need functional assistance, like they have disability where they need at least 3 or more ADLs, most of the individuals. And people in the nursing homes are mainly women, because we tend to live longer after a certain age, and widower. Many stayed for short term after a hospital stay to get rehab, and a few would stay for longer, like permanently. And cognitive impairment is very common in nursing home. Next. Here are some of the resources for caregivers. CMS, for example, has a lot of information on comparing different nursing homes. Healthy Aging has a lot of resources for caregiver and even screening tool. The National Institute of Aging also have some tools that you can use. Thank you. These are the resources that I use for this presentation. Thank you so much for the opportunity.
Thank you, Dr. Kuruma Nelson, for that wonderful presentation. It's definitely very, very important to distinguish between the types of care facilities that we have. Thank you for the statistics that you provided earlier on in the presentation. I do have a few questions that have come in during your presentation, so I'm going to go right into them if you be kind to answer those questions for us. So the first question that I received was, in your view, what accounts, earlier when you talked about the statistics and how Hispanic men live longer, I was like, oh, wow, I didn't realize that. So in your view, what would you say accounts for that higher life expectancy among Hispanic men? I mean, across the board, it just not only just Hispanic men, but like Hispanics across the board. But specifically, this person is asking that what do you think is contributing to that higher life expectancy among Hispanic men after age 65? Thank you.
Thank you. That's a very important question, because I feel like what we do when we're younger affects us later on in life. So we are what we eat. So the type of food that we eat, the type of activities account for the changes. So the first generation Hispanic men and women tend to live a healthier lifestyle. They are non-smokers. They eat at home. They don't eat fast food. So, and they're more active. That contribute, but that statistic would change because as you look at second and third generation, the habits change where people are smoking and eating out more on healthier food options. So the way that I think we can actually increase our life expectancy, it's the lifestyle that we live. We need to pay attention to what goes into our mouth. And yes, life is stressful. We need to make time for 30 minutes of exercise and meditation. Those would make changes later on. Thank you.
Thank you so much, Dr. Kuruma. I think when you said we need to watch what goes into our mouth, I was like, oh, she's speaking to me. And I'm sure a lot of our listeners will agree as well. And I certainly agree with you that what we put into our mouth determines what our body shows on the outside. So thank you very much for answering that question. Along with that question, someone had also asked, why is life expectancy higher for women? So you mentioned earlier that after a certain age, women tend to live longer, and there are more women in the nursing homes because there are widows, and so what do you think is contributing to women living longer and more women being in the nursing home? I mean, I guess beyond as a woman who's a widow, obviously her husband has died, and maybe doesn't have all the resources that she needs to take care of herself in the house. But I'll let you answer because you're the expert in this conversation. So go ahead, Dr. Kuruma-Nelson.
Remember, a lot of the statistics are we're seeing older adults from previous generation. So this might change because the previous generation, women were not working as much. They were restricted to a certain level. So yes, they have their own stress, but it's very different from the stress that current working female are encountering. So that may change actually in the future. So I think the reason is, again, the previous generation, the men were working more, they encounter more stress that they don't have control over, versus, yes, there's stress at home that women encounter then, but there are certain things you can do to help control that stress, like work stress, for example. So I think in the future, this is going to change because currently women are working and having the same type of stress or even more than men. So actually, my prediction is our life expectancy might actually decrease because we have not stress of work, also stress at home.
Wow. Well, I pray for women in general that our stress will reduce. But thank you very much for answering that question, Dr. Kuruma-Nelson. Another question came in. How can we protect our brain activity? And also maybe along with that question, you can also answer this one. Considering the reduced kidney function with aging, how does one balance increased medication use that comes with age associated with diseases such as hypertension, diabetes, and again, reduced kidney function?
You'll probably be tired of me saying lifestyle changes. So for kidney function and hypertension, all of this condition, it's not only has to be addressed with medication, lifestyle changes. Again, watching what you eat, minimizing salt. Mediterranean diet have been well studied as one of the best diets because it has a lot of anti-inflammatory food in it. For example, like my staple is rice. So I've learned that I can substitute quinoa for rice. It takes a while for you to get used to it, but eventually you're like, oh, it tastes the same at once your taste buds get used. So those are some of the little subtle changes you can make that makes it different. And that would minimize, I'm sure later on, my risk of diabetes because the glycemic control for quinoa versus rice, very different. And for your cognitive function, there's a well-studied diet called the MIND diet, which basically consists of anti-inflammatory, and you can search that. It's really available. It was, I think, studied by Duke, and there's a lot of evidence behind it. So I would encourage people to incorporate some of the foods. It's usually colorful food, anti-inflammatory. The more colorful food your food is, the better. The less processed, the better it is for you. And to stimulate your mind by doing activity, there is something called luminicity, which is, you can search that online. It's a website that you can do brain exercise. I do it sometimes, and some of it I get wrong, but it helps kind of keep you stimulated.
Thank you, Dr. Kurma Nelson. I'm certainly aware of luminosity.com. You're right. Some of the questions are like, oh, it looks easy. Why didn't I get that right? But it is brain activity exercises that are super helpful. Thank you so much for sharing about the mind diet as well. One other question, somebody did ask about the GATE training. You mentioned about the GATE training and the National Institute website. Could you please repeat that website for our listeners so that they can go back and access that that website to see those different types of trainings and exercises?
It's the National Institute of Aging. It's part of the NIH.
Okay. Thank you so much.
Thank you.
Thank you so much, Dr. Kuruma. We really appreciate you being here, sharing this information with us. And I'm definitely sure that listeners on YouTube are learning and writing down, taking notes. So thank you so much for sharing your knowledge with us. She did mention something about anti-inflammatory diet. And with that said, I'm going to welcome our next panelist. I hope you guys are learning, because I told you we have great panelists in our midst today who are going to be sharing knowledgeable information. So before I have our next panelist on the screen, let me introduce you to Dr. Fakia, Dr. Emma Olufunke Fakia. She obtained her nursing certificate at UCH Ibadan, Nigeria, her bachelor's and master's degree in human nutrition at University of Ibadan in Nigeria. And she also obtained her master's and doctoral degree in public health at Walden University, United States. She is certified as integrated nutrition and health coach. Dr. Fakia worked as a nurse, a nutritionist on UNICEF programs and procurement officer for World Bank in Nigeria. In the United States, she worked as a registered nurse at Howard University, Howard University Hospital for over 10 years. Currently, she works with ORET Healthcare Enterprise as a public health director in charge of health education on cardiometabolic health problems. And she facilitates the NCLEX-RN review. I guess that's for like the nursing exam preparation. Listeners, viewers, please join me to welcome Dr. Emma Fakia. Over to you, ma'am.
Good morning, everyone. I'm so excited to be in your midst this morning. And I really appreciate Rapha Ministry of Jesus House Dise for inviting me to this forum. Thank you so much. Without wasting much time, I'm going to discuss about the aging process. And my area of concentration will be on chronic diseases, because these chronic diseases is very common among the old people. So that will be what I will be talking on. And so in my outline, I will talk about what is the aging process, what is the link between aging and chronic diseases, why should I care about chronic diseases, and what can I do to prevent or manage chronic diseases. Okay, so before going on, let me just define what aging is. Aging is the process of becoming older. That is, when we are born, we are baby, from baby to preschool, then adolescents, the younger adults, older adults, then old age. It is a gradual and continuous process of natural change that begins in early adulthood. During early middle age, many bodily functions begin to gradually decline. It's just like a car. When you are driving a car for a long time, there will be depreciation. So it's the same thing with the body. So as we are getting older, that's gradual decline in what we do in our functions. And aging occurs as a result of cellular wear and tear, and it is related to genetic, environment, and lifestyle factors. Genetic, environment, lifestyle factors, they interplay in causing early aging. You can see somebody of 60 years age, two of them studying together, then one will be younger than 60, and the other one will be older than 60. Then you begin to wonder what happened. It's because of the genetic disposition, it's because of the environment full of obesogenic environment, that is an environment that makes you fat, that does allow you to do exercise. Or it may be your lifestyle, maybe like smoking, maybe like excess alcohol, and then unhealthy diets. All those things will contribute to premature aging. And so we can see the diagram from the baby to the preschool, to the adolescent, to the older adults and older adults. So those are the stages of aging. So I'm now going to talk about the expected changes due to the aging process. The previous speaker has really talked much about this, so I will just mention some of them, which has not touched. Number one, there's a decreased ability to taste. When you are getting older, there's decreased ability to taste. And this is very significant because of our salt intake. Because when you eat your food and you don't feel that that is tasteful, there's a tendency for you to add more salt. And then salt causes hypertension. So we should be aware of that. The decline in vision as we are getting older. And also because of these chronic diseases such as diabetes, it affects our eyesight. Even hypertension as well affects our eyesight. And so decline in vision as we are getting old. Then reduce in muscle stress. There's reduced in muscle stress, there's reduced in a lean mass during the whole day. As a result of that, the whole people, they are susceptible to fall, as the presenter has mentioned. Also, there's decreased immunity. There's increased immunity in old age. That's why the government was worried when we have this COVID-19. They were worried about the whole people because they have decreased immunity. So also we have hormonal changes, especially among women, because around this time, there is no more menstruation, no more estrogen. So there's a tendency for osteoporosis. And when there's osteoporosis, you are likely to break your bones. You are likely to fracture. So that's why it is very, very important for the whole people to be very careful. There should not be any water spilling on the floor. It has to be more because they can fall easily. And then there's increase in body fat, especially for abdomen. This abdominal fat, I'm going to stress it. You can have fat in other place, but the one in the abdomen is very unforgivable. Why? Because the abdomen is very close to the vital organs. It's very close to the heart. It's very close to the liver. If you have fat in the abdomen, the fat can split into your liver and causes fatty liver. And then the fatty liver, the dangers of it is also the same thing as somebody drinking alcohol. It can lead to cirrhosis. So abdominal fat is not advisable at all. We need to reduce our abdominal fat. So the next thing I'm going to talk about now is about the link between aging and chronic diseases. There's a link between aging and chronic diseases. We should not be fearful of old age. Old age should be enjoyable. It is not that old age is causing the diseases, but related diseases as a result of old age. That's what we are talking about. You can live your old age without having any diseases at all, because the Lord said we should have life and we should have it more abundantly. He said we should have it abundantly. So you can live a life throughout your lifetime without you having any illness if you take the prevention. Like Moses in the Bible, we were told when he was even old, he was able to see very well. That's what God expects from each and every one of us. So we need to take, we need to do our whole part. So inflammation is the better part of the immune system response to injury or infection. That is, inflammation is okay. It happens. Supposing you have a wound, that place becomes red and swollen. That's inflammation. Helping to fight against those germs. So it is okay. But if this inflammation becomes chronic, in you, it causes diseases. And so we have this chronic inflammation, and it leads to all these diseases of old age. The first one is cardiovascular diseases. When you have these cardiovascular diseases, you have cardiomyopathy, atherosclerosis, and stroke. And then with the stroke, death can occur as a result of chronic inflammation. We also have neurodegenerative diseases, which is Alzheimer's disease, Parkinson's disease, which are common in old age. Then also we have a metabolic syndrome. Metabolic syndrome consists of about 5 things, but the major one is type 2 diabetes, then fatty liver diseases, and then high cholesterol. The whole causes a metabolic syndrome. Then from chronic inflammation again, you can have cancer, gastric, liver, lung, gallbladder, colon, rectal, pancreas, and prostate. And then also with chronic inflammation, you can have musculoskeletal disorders such as osteoarthritis, osteoporosis, and sarcopenia. So all these things, they come from inflammation. So then, what causes this inflammation? So it is what we are going to look at next. Okay, before that, let me just give you a rough idea of what is happening in old age. From statistics, about 80% of older adults, they have at least one of these chronic conditions. 80%, that is 4 out of 5 adults, they have at least one chronic disease at age 65 plus. And then about 68% of them have 2 or more chronic diseases. And then we also have 58% having hypertension, 47% having high cholesterol, 31% having arthritis, 29% having ischemic heart disease, 27% having diabetes. What I can say about these chronic diseases, they are like cousins, they are like brothers, they are like sisters, they go together. When you have diabetes, there's the ability for you to have a high blood pressure. When you have a high blood pressure, it results into heart problems. So they work hand in hand. When you have one, it leads to the other, it leads to the other. And before you know it, you have about 2 or 3 of all these chronic diseases in your body, and it should not be so. And one good thing about these chronic diseases is that it is preventable. It is very, very preventable. If we do the right thing, we talk about that one as I move on. So those are the ones. Now we want to talk about the causes of this inflammation, because we don't want this inflammation to be in our body. As we are getting older, we don't want to have this inflammation at all, because we have seen that this inflammation can cause a lot of chronic diseases, and it will not allow the whole people to enjoy their life. And God has already given us life to be enjoyed. So number 1, lack of adequate sleep. Sleep is very, very important. Quality of sleep is very, very important. Lack of adequate sleep causes a pro-inflammatory, which can lead to inflammation. And then because of lack of adequate diseases, there's a decrease in immunity. So it is something that we should be looking forward to have a very good sleep. Another thing that can cause inflammation is our poor diet. Eating sugary things, sugar-sweetened food, high carbohydrates, high calorie diets. All these things can cause inflammation. Processed food, unhealthy diet is another thing that can cause inflammation. Then too much alcohol intake, taking too much alcohol. And then lack of regular physical exercise. We can continue to talk about advantages of physical exercise from now to tomorrow. It has a lot of advantages. Then emotional and physical stress. Emotional and physical stress. This emotional and physical stress, and the last time I went to the public health program, they said even this started from childhood, especially among women. Maybe they were abused, maybe because of the environment they are born to, maybe because of socio-economic condition, and all those social determinants of health. They account for all this emotional and physical stress, and it affects us. And also even the type of work we are doing. Sometimes we are working, we are not happy with the work we are doing. And so this work can cause stress because we are not doing what we are supposed to do, what we enjoy doing. So it will cause inflammation. And then unhealthy oils and bad carbohydrates, all these things can result into inflammation. So why should I care about aging and chronic disease? Why should I care at all? We need to care about chronic disease because of poor physical and functional status. Like I said, let us take one of them, diabetes. When you have diabetes, it affects all the organs of the body. All the organs of the body. It will affect your eye, it will affect your kidney, it will affect your neurons, everything. So because of that, there's a poor physical and functional status. Then number two, when you have this chronic disease, maybe you have one, you have two, you have three, then you have many medications. And each of these medications, they have their side effects. We have adverse effects. So by the time you are taking too many of them, polypharmacy, you are having a lot of reactions going on in your body. Number one, you are taking care of your health. And at the same time, there are some reactions coming from the medication you are taking. So you don't want all these things as you are getting older. Also, it can affect activities of daily living. Taking an example, diabetes. If you have diabetes and you don't take care of your feet, it can be amputated. When it is amputated, you cannot move around. So you have to be on a wheelchair. So that is why you have to prevent all this. And also, high cost of healthcare. I think the diseases of the old age is what is keeping the government, keeping them awake at night, because they are spending a lot of money on chronic diseases. And for individuals too, out of pocket, going to the hospital all the time, all these things, they add up and then causes expensive living. And so now we want to talk about how can we prevent these chronic diseases? How can we prevent this? Because the good thing about these chronic diseases is they are preventable. So let's look at illness and wellness continuum. So let's assume we are in the middle, in the neutral. So you are now in the neutral. You don't have any symptoms, you have adequate nutrition, but you have inconsistent exercise, and your health is not all that high priority to you. So you can move to the right so that you can have good health, or you can move to the left. So to the left, you have poor health, symptoms, drug therapy, surgery, and loss of normal function. Then to the extreme left, disease occur, multiple medications, poor quality of life, and potentiality limited bodily functions. But it's advisable for us to go to the right, to move to the good health. And when we go to the good health, we have a regular exercise, good nutrition, wellness education, and minimum nerve interference. And for the optimal one, we are doing okay, 100%. We are taking our medication, we are eating good, we are having exercise, we are sleeping well, we are doing what we need to do. And before I move along further, in one of my integrated nutrition class, we were told about primary food and secondary food. I learned that for the first time, primary food and secondary food, but by one of our lecturers, Joshua. So what is primary food? There are three things about primary food. One is physical activity. The second one is your faith. Then the third one is your career. And then number four is relationship. So when this one is balanced with your secondary food, which is your food, then you will have optimal health. Now, how can I prevent and manage chronic diseases? As I said earlier, all those diseases I mentioned earlier, they can be prevented even right now. Right now, they can be prevented. Even some of these can be prevented at birth for women in their productive age. When you have your baby, breastfeeding for the first 6 months of life, exclusive breastfeeding. If you cannot do it for 6 months, try to do exclusive breastfeeding for the first 3 months of life, because data have shown that babies that are breastfed, that the diabetes is being more reduced among them, and some of all these diseases. So it starts from birth. The environment the child is born to, the care and the loving environment. The baby should be cared, should be loved, and then give the baby breastfeeding, and then good diet in the first years of life. It will prevent all these chronic diseases happening in the later years. As I said earlier, sleep is very, very important. Get at least 7 hours of sleep at night. Quality sleep, especially towards 2 a.m., 3 a.m., 4 a.m. Those periods are very, very important, because when you sleep, you allow your brain to rest. Your sympathetic nerve is at rest. So everything should be done. You should sleep at least 7 to 8 hours every day. Then eat a healthy diet. What is a healthy diet? Healthy diet is a diet that is based on plant-based, mainly plant-based most of the time. They're all grains, not processed food. When you process your food, you have removed most of it. For example, our pap, in our native language pap. By the time you make that pap, you have removed the bran of the maize, and that's where we have all these vitamins. So the same thing with the flour we use for bread. We have removed everything. So by the time we are eating all these things that are just rubbages, so we need whole grains. We need whole grain like coca oats. Coca oats is very, very good. And it's even recommended for those people that have high cholesterol. When you take coca oats every day, I start for it to reduce your high cholesterol. Eating healthy diet. The previous speaker talked about Mediterranean diet. Mediterranean diet should be encouraged. And what is Mediterranean diet? It is a diet that consists of olive oil. They use olive oil to cook. And then they eat fish. They eat fish, and then they eat a lot of vegetables. So we should encourage that as we are moving along. Then maintain a healthy weight. Maintain a healthy weight. Healthy weight is very important. How can you do this? You can do this through diet, and then you can do it through exercise. And with the exercise, we have two types. We have the aerobic one, and then we have the stress training. That is walking. You can walk. You can walk around. You can do everything. I think the recommended minutes in a week is like 150 minutes of walking in a week. So you can do this. Then if it is swimming, it's okay. Then you can also do lifting. Lifting is another way of doing exercise. And then you can do cycling. It's another way of doing exercise. Then engage in regular physical activity, then have a great social support. I will talk more about this social support because it's very, very important. And then the last one is hold on, please. I think that one is regular exercise as well. So these are the way you can prevent this chronic diseases. Once again, to stress it further, you have to sleep well, eating healthy diets, maintaining healthy weight, engage in regular physical activity, and have a great social support. Well, people will be saying we have had about all this all the time. So what can we do differently? What we can do differently is to recognize 3 Ds, 3D, A, B, C, D, 3 Ds. What the first D? The first D is determination. You should be determined that I'm going to lose weight. I'm going to do exercise. I'm going to work. I'm going to do this. That's the first D. The second one is discipline. You have to discipline yourself. Maybe you are the one taking Coke every day. You will discipline yourself that this week I'm going to take a bottle of Coke this week. Or maybe you are eating ice cream all the time. So you need to be determined. You need to discipline yourself, and then you need to have a diet as well. Then another thing you have to consider too, when you want to be intervention programs, is what we call health belief model in public health laws. Health belief model. What is health belief model? That is, there's a disease, and you know you are susceptible to this disease, and then there's the severity of this disease. And so since you know you are at risk of this disease, you want to do something about this. So that's why you should gear you up. That this preventive, I'm going to do is, I'm going to discipline, I'm going to discipline myself, and I'm going to use diet to control all this thing. And it is achievable, because I've seen it in one of our clients. She came to us, she has a high cholesterol, her BMI also was very high, overweight. Then she has this abdominal fat. But because she was determined, and because she's disciplined, so we put her on diet, and we put her on a physical exercise. And after 6 months, she has lost that weight. She's eating healthy. The cholesterol has come down, and she's doing fine. So it is something that we can do. We have to determine, we have to be disciplined, and then we have to look at our diet. And then health belief model, you should not susceptible to this infection, because it's some family genes. Maybe they have diabetes, and you know, in my family, we have diabetes. I have to do something about this. I don't have to take sugary things. I have to exercise. So all those things should gear us up, instead for us ignoring it. So I want to talk more on this social support, because it was what I wrote my thesis on, about the effect of social support on glycohemoglobin. A lot of researches have been done on social support, and that social support has really helped to reduce some of these chronic diseases. So before going on, I want to divide social support. It is the assistance given to a person by providing information, resources, and socio-economic aid. Information support is receive advice, information, guidance, and feedback. Also, another one is emotional support, express feelings, and receive encouragement. Then we also have tangible support. That is in form of receive material aid and financial assistance. And then appraisal support, that is empower people to lead them to available resources. So as we are going older, we need this social support, especially those people that already have this chronic disease. They need social support. They need somebody by their side to tell them when is your next doctor's appointment. How do you get there? They provide a vehicle for them to go there. Then your insulin. Let me see your insulin. How are you doing this? How you are doing that? They're providing for them healthy diet. And then for that person that is deceased or declined, that person should have a self-efficacy. Self-efficacy is that I'm able to do this. I'm able to do this. And before that person can use that self-efficacy, that person must be empowered. Empowered, set a small goal for them. Little goal at a time, small, but they have to be consistent with that goal. When they are consistent with that small goal and they achieve it, clap for them, celebrate them, then they move on. They move on. Social support is very, very important. And the people that give social support, it can be the immediate family, spouse, or children. From my thesis, I found out that the spousal support, they are the one that gave the higher social support. The spouse is very, very important in the house. Very, very important. That's why both of them should live amicably, because they need each other, especially at this old age period, because they look after each other. Another one is the extended family. We can have siblings, we can have aunts, we have nieces, and can have nephews to give the social support. We also have friends, neighbors, colleagues, peer members of social group, and also we have a faith-based organization such as churches, community health workers, and so on. So at this point, I really want to emphasize about this social support. We have positive social support and we have negative social support. Negative social support is you giving support to somebody, but you are complaining, you are grudging, this your healing, it is too much, you are wasting my time, I cannot do this, I cannot do that. So that the negative aspect of the social support. But the social support we are talking about should be positive, should be emotional support. You have to reason with that person. You have to put yourself in the shoe of the other person. Another thing I want to talk about is about the faith, the role of the churches in giving this social support, because there was a positive things about this when I did my research, that the church, they play a very significant role in supporting the whole people social support so that they will not have chronic disease. There are so many ways the church can partner with the clients, with the family. The one of those is what we are doing right now, arranging seminars, arranging webinars, teaching, all the time. That's number one. Then number two, in our small group, our women group too, we always invite people to come and talk to us on Wednesdays all the time. That's another way we can talk. The other way we can talk as a church to provide social support is like, apart from God, the next thing we look up to is our pastors, is our ministers. And so they should use that, they should use that to give us positive things, like this coronavirus vaccine. I know that our pastors, Pastor Gandhi, always come to the pulpit and tell us, you people, go and get your vaccine, go and get your vaccine. And because your pastor is saying that, then you'll be compelled to go and do it. So the church, they play a very, very important role. And apart from that, prayer, faith, they build your faith up. Even when you are going through a challenge, it's through a difficult situation, they give you the support. So we need one and another as we are growing older. We should identify who our social support is, and we should network with them so that if anything happens, they know what to do. Instead for us living like in an island, nobody knows what is going about you. You are just inside the house. Something might happen to you, you may not know. So social support is very, very key as we are getting older. Then health screening for chronic diseases. We need to do health screening. It helps you to identify if you already have a risk for a particular chronic disease. You need to know whether you have a risk. You have to do risk assessments. Then health screening starts at various stages, and the recommended age can change based upon guidelines. Most of this health screening starts at age 50, but if you are at risk of a particular disease, maybe in your family they have cancer there, in your family they have diabetes, then you can talk with your doctor. Maybe they can do it earlier than 50 years of age. Then examples of health screening relevant to the elder include hypertension, diabetes, high cholesterol, cardiovascular disease, cervical cancer, breast cancer, and so on. And if you have a family history of any of these conditions, as I said earlier, it is important for you to tell your doctor, let your doctor know about your family history, so that maybe they can start it earlier than the recommended time. So as I'm writing up, I'm just using this acronym track to remind us of what to do again. Number one, the first is take your medications as prescribed by your doctor. And then R, reach and maintain a healthy weight with a healthy diet. Hey, add more physical activities to your daily routine. C, control your ABC, your A1C, that is your hemoglobin, blood pressure, and cholesterol levels. And then kick your habits of smoking and excess alcohol intake. So we should not forget about this. So at this time, I really thank you, the organizers, for giving me the opportunity to talk at this forum. Thank you, and God bless you all.
Thank you, Dr. Fakia. Wow, you did an amazing presentation. Again, listeners, I did mention that grab your pen, grab your paper, grab a pencil, and you will learn one or two things, not only about aging, not only about the types of facilities we have, but how our body interacts with what we put in, and what we put in affects what we put out in our body. And inflammation, I didn't even recognize, I didn't know, and I'm in a healthcare field, I didn't know how much inflammation can impact the body. It impacts every organ, like she said. One thing that Dr. Fakia said earlier that I will not forget, and I wrote this down, is abdominal fat is unforgivable. And I was like, ooh, that is so true. Abdominal fat is unforgivable. And I think that what that has done for me is to keep me I'm very conscious of, again, what I'm putting in my body, the bread, the rice, finding healthier options so that this abdominal fat does not become unforgivable. It doesn't get to the point where it becomes unforgivable. Thank you so much, ma'am. A couple of questions that I would like to ask. Well, one main question, because you did answer a lot of the questions that were coming in. Somebody did ask, what is cardiomyopathy and atherosclerosis? And I'm thinking those are different, or I don't know if they're the same or if they're one issue. If you can answer that. And then also along with that is the difference between osteoporosis and osteoarthritis. If you can briefly answer those questions for us, ma'am. Thank you.
Thank you very much. Cardiomyopathy and atherosclerosis, both of them, they have the same origin. They have the same origin because of eating bad diets and bad fats. We call it saturated fats because it is the hydrogen carbon is saturated fats. And so these fats, they are the ones solid at room temperature. So these are not very good to the body. So these fats, we get them more from animal fats. When we take more of meat, more of all the internal organs, pancreas, you know, some people, when they want to eat, they will have a bowl for their main food. They will have another bowl for meat, assorted meat. This is very, very bad. And so this is where the problem starts. So when we eat all these animal fats, and when we put them in our body, then they occur our artery. So the artery is occurred. And so it will form a plaque. Because it forms plaque, it will not allow the blood to flow freely in our arteries. And so all these things will develop. How we develop is atherosclerosis, causing heart problem. And this cardiomyopathy is something about the heart, about the muscles of the heart. So the origin is from our food, or excess sugar, excess fat, bad fat go into our body. So that's why we need to eat food from the plant sources, and use the good oil, like the olive oil that I talked earlier is very good. So we need to avoid all this so that we don't have atherosclerosis or cardiomyopathy. So like the osteoporosis and then osteoarthritis. That one deals with the joints of the body, the joints. And as I said earlier, it's as a result of inflammation. It's as inflammation. That's why we have this osteoarthritis. But with the osteoporosis, it's a disease of the bone, the reduction in the bone mass, which happens among women after menopause, osteoporosis. So it starts gradually from osteopenia to osteoporosis due to lack of calcium, vitamin D. So what we can do to prevent all this is walking, and then intake of calcium, intake of vitamin D. We can also get calcium also from our leafy vegetables, especially from our kale. Kale is very good in providing calcium for us. Thank you very much.
Thank you so much, Dr. Fakia, for answering those questions. I know that personally, I have to increase my vegetable and green leaf intake. Thank you very much. I've definitely learned about how inflammation can impact our long-term health, and just like Dr. Kuroma Nelson mentioned earlier, and Dr. Fakia also mentioned, what we put into our body does have that long-term impact. So you might be enjoying that bowl of meat right now, but think about its impact on your health down the line. So having had Dr. Fakia explain how chronic diseases can impact one's body, I think that, and not just me, but the entire team who put this together also believe that it's important to learn about the policy, the health policy, especially for us who are living here in the United States. It's important to not only know about the long-term care, the types of facilities that are available, how what we eat has long-term impact on our health and our physical body, but to also understand the health policy. And we have here in our midst a health policy expert and lecturer by the name of Miss Chinonye Onwunli. Ms. Onwunli has our MPH and MS, and she is a senior policy analyst at the Office of the National Coordinator for Health Information Technology. She's a staff division of the Office of the Secretary within the United States Department of Health and Human Services. Her work involves health IT regulation and policy development, as well as Medicare and Medicaid policy coordination and advertisement. Ms. Onwunli is also a lecturer of health administration at the New York University's Robert F. Wagner Graduate School of Public Service. Prior to federal service, Ms. Onwunli was a Medicaid expenditure analyst with Florida's Agency for Healthcare Administration, where she worked on implementing the state's long-term care managed care program and evaluating Florida's long-term care waivers. Ms. Onwunli is committed to equitable access to quality care across the healthcare continuum. Ladies and gentlemen, welcome with me, Ms. Onwunli.
Thank you so much. Thank you so much, Latunde, for such a wonderful introduction. Again, my name is Chinonye Onwunli, and I'm so happy to be here with you all today to talk about the financing around aging and long-term care. I consider myself blessed to be able to share this information with you all today because this isn't a conversation that we always have and that we always have in a setting like this. Again, it's very important for me to state that while I am an employee and a policy analyst at the U.S. Department of Health and Human Services, I am not here on behalf of the department at all, and I'm here to represent myself. And anything I say is not on behalf of the department. So again, as we have heard from the previous speakers, as we age, we incur greater needs, we have greater specialized healthcare needs, and of course, then greater financial needs. It's just as important that we think about how we're going to take care of ourselves, again, as we're thinking about retirement and we're thinking about aging, that we know how to navigate the government healthcare system or the healthcare system in general and its costs, and that we start thinking about how we're going to pay for where we live, and if we have to be in a facility, et cetera, more importantly, and its costs. And it's because long-term care is expensive, and we have extensive programs, and we have to learn how all these different programs play a part in being able to support your financial needs. So we're going to talk about some of the settings that we spoke of earlier from the previous presenters, nursing homes, assisted living facilities, skilled nursing home facilities, and home-based care. So the two major healthcare programs in the country is Medicare and Medicaid. Medicare is a federal health insurance program that covers people age 65 and older, certain individuals with disabilities, and those with end-stage renal disease or kidney disease, those that need constant dialysis. There are currently 61 million individuals here in the United States that are on Medicare, and 53 million of those individuals are there for age-related purposes, so they're over the age of 65. Medicaid is a government program that provides coverage to low-income individuals. So you're thinking of your low-income adults, often mostly women. In some states, they allow men, children, low-income children, and pregnant women. You have your low-income elderly adults and individuals with disabilities that also have to be low-income. So we hear about these programs and we often don't always understand the difference. So we talk about it sometimes interchangeably, but there are important distinctions. Next slide, please. So Medicare is federally administered, meaning if you are in Colorado, if you are in the state of Florida, if you are in Mississippi, and you are a Medicare recipient, your benefits are going to be the same. It's going to look the same wherever you are. Medicare is deducted from your income. So when you get your check from your job, you will see a Medicare deduction, along with Social Security, which is outside of the scope of this presentation today. The Medicaid is jointly administered, well, it is a jointly run program with the federal government and the states. So the federal government puts money with the state's money, but the state is the one that administers. So they design their own program, and you will have different programs from state to state. So if you're in Mississippi, your program is going to look vastly different from Vermont, and it's going to look vastly different from the state of Florida again, because a lot of the influence around benefit development and program development in Medicaid is influenced by the financial health or financial status of a state. So which state is richer or poorer, if you will. The demographics, because there are different racial makeup in California than there is in Vermont, and therefore come with differing healthcare needs, and the political climate of the particular state. So you can have a state with a certain conservative state with the same racial makeup, if you will. California will look different in Medicaid benefits than a similar racial makeup, say Texas, that is more conservative. So you have a liberal state and a more conservative state, and they will be conservative in spending, and another one will be much more liberal in spending. Medicaid, very importantly, does not come from your income at all. So it is, again, managed from whatever the state has in its coffers. So it is somewhat influenced by your property taxes, your state sales tax, that sort of thing, but it does not come from your income. Next slide, please. So we will talk about Medicare, and Medicare specifically first. And Medicare has three, before I get into the fourth, three distinct parts. So you have Medicare Part A, and you think of it as the coverage for your hospitals. It covers inpatient hospital stays, skilled nursing facilities, your hospice care, and in some healthcare services that you will have at home. While your Medicare Part B generally covers your doctor visits. So think of your doctor visits and everything around that. So your durable medical equipment, if you need a nebulizer and you're older and you're a Medicare recipient, it will pay for those things. It pays for outpatient care. It pays for your preventative services, so your screenings and the like. Next slide, please. One of the things, I think there's a slide in between. Can we go back one slide? Okay, well, it's missing a slide. However, I have that slide here. There is a Part C, Medicare Part C. Oh, no, that's not true. I apologize. I mixed my own stuff up. If you can go back to the next slide. No, okay. I'll just go off the cuff. So Medicare Part C is also called Medicare Advantage. Medicare Advantage includes Part A, Part B. Okay, so 1 second. This really is out of order. So there is one slide that's missing. All right, off the cuff. So it includes Part A, Part B, and Part D, which we'll talk about in a minute. Part D is your prescription plans. So Part C takes all of the different 3 distinct parts and puts it into one and is administered as an HMO or your managed care organization. Your managed care organizations, you're thinking of your Aetnas, your United Health Group, your Cignas. They're the ones that you can be a Medicare recipient, but if you go into a managed care program, it's administered as a managed care program. And that's important because using them as different parts creates different gaps in between coverage. So we have Medigap, which is used to address some of those coverages, those coverage gaps. So you have premiums that are not necessarily, you don't necessarily have to pay a premium for Medicare Part A. If you don't have a certain income over, if you make too much money, so you can make too much money for Medicare, but generally Medicare Part A, people don't pay premiums for. You do, however, pay premiums for Medicare Part B. You will not necessarily have to pay the same type of structure if you are in a Medicare Part C program. So that's supposed to be holistic. You don't have to really worry about it. It's administered like your health plans at home. Medigap is if you choose not to do that, but you have your Part A, you have your Part B, and there are inconsistencies, if you will, or there are co-insurance pieces that you have to pay. So important pieces include I think it's $174 per month for the premium for Medicare Part B. If you make too much money, and that's around a 6-figure income as a retiree, you'll have to pay a little bit more than that premium per month to get the benefits. There are also, and we'll talk a little bit further, if you are in a skilled nursing facility, I'm giving you an example. If you're in a skilled nursing facility outside of your, you get discharged from the hospital, you would have to pay an amount past the first 60 days. So Medicare will pay for the first 60 days, and then 61 days to 100 days, you have to pay 20% of what they pay, which is $374 per day. So imagine having to pay $374 per day for maybe if you have to stay for 3 months, that's 30 days. So Medigap will help you pay with some of these, co-insurance issues, and that's sort of like a wraparound policy. That being said, what is the difference between Medicare Advantage, which again is your idea of your general HMO, your Humana, your Blue Cross Blue Shield, although it's not included here, versus Medigap, which is also a privately run health plans that administer the same thing. They both have to be sanctioned from the federal government. So Medicare approves these said plans. These are the ones that you can go through. So what are the differences? Medicare Advantage works, again, like an HMO. Let me go back. Medigap works as a PPO. So think of it as a PPO. If you all are familiar, PPO, you can go wherever you want in the country. And as long as they take Medicare, you can be seen by that doctor, which is really great because a lot of people, Medicare is widely accepted. So if you want to go, and let's favorite example of your grandparents and your granddaughter and your grandson have a child in Texas and you want to go visit and you get sick, don't have to worry about who's going to see you. However, in that same example, if you are a Medicare Advantage beneficiary, a Medicare beneficiary in that particular program, you are limited to your network. So again, the same way we think about Kaiser. I know a lot of individuals here have Kaiser. So if you are in Kaiser, you can't really go see anyone else unless you're in, you have to pay out of network costs. So you have to think about all of those pieces and how you are restricted with these programs. And so Medigap does not cover long-term care or private duty nursing. And it doesn't cover dental care, hearing aids, vision care, eyeglasses. And these are some of the services that you more than likely will get should you choose a Medicare Advantage plan, because once again, it works quite similar, if just as well in the same structure as your employer-based or sponsored programs. Next slide, please. Okay, so this was supposed to be first. So we covered, Part D. So we didn't talk about Part D. Part D is where they cover your drugs. So that's a separate part. And this also has a deductible. The deductible is on average $33 a month. So think about it, you're paying $33 a month for Part D, you're paying $174 a month for your Part B. And this is money that's coming out of your retirement. This is not you working, this is money that you're coming out of your pocket. So it's important to think about, when you also have to pay premiums for Medicare Advantage. That was important to say. You have to pay premiums for your Medicare Advantage, and Medigap insurance sometimes is more expensive than your Medicare Advantage. So you have to also weigh the costs on, are you traveling often? What's your lifestyle going to be as you retire? Are you going to, take one of those RVs and go across the country? Are you, what are your needs? And those things are really important as you think through things. Next slide, please. All right, so Medicaid. After we've talked about Medicare, Medicaid, again, is a state and federal partnership. It's administered mostly as a fee-for-service in different states or managed care. So you have then managed care companies contracting with the state to provide a bucket of services for each Medicaid recipient. There you have your same players, your Humanas, your Cignas. You have Blue Cross Blue Shield here in this area that works as a Medicaid HMO or a managed care organization. And so it's going to look different. I think I spoke to you a little bit earlier again about how it looks different across different states. So based on the demographics of a state and the financial health of the state and the state politics of a state, you will get a variety of different services. So in one state, they cover children in their hearing. In another state, they only address adults age 65 and older and their hearing, and not for children. And so it varies across states. However, there are federally required services that the feds mandate that each state cover. So these things include inpatient and outpatient services, nursing facilities, home health services, and non-medical transportation or non-emergency transportation to care for their patients. So Medicaid will pay for you to go to your doctor's appointments, to go to your screenings by mandate, by law. So you're supposed to do those things. And that looks, again, different in every state. So it could be that a state contracted with a transportation service to take you around and you have to sign up for that and be on the rolls for that. Or it could be just as simple as reimbursing you for your Uber. They do have states that do those things. Medicaid also works sort of as a Medigap, if you will, for those who have low income. It pays for your Medicare premiums and the cost sharing, again, for those who are able to qualify for Medicaid. And we call those individuals dual eligible. So if you are ever hearing on the news and they're talking about dual eligible individuals, or they're having those kind of conversations, we're talking about those recipients who are on Medicare and qualify intermittently at times. We'll talk a little bit later about eligibility times for Medicaid, but also eligible for Medicaid. I think I said this already, but touched upon how additional services, dental is not covered everywhere. So you would think that that would be a pretty easy staple to have, especially if you're thinking of individuals that are 65 and up, that they will have dental care issues and they should have regular exams. And we know that Studies show that heart disease is linked to your oral care as well. This is something that's important. However, again, thinking of your states, if your state doesn't have as much money, like Mississippi, that's not something that they will be able to cover based on their demographics. Now, Medicaid, compared to Medicare, is not widely accepted. You will be hard pressed in certain areas to find someone that takes Medicaid. And oftentimes it's because of, one, the way that it's structured, and number two, how much physicians, your clinicians are reimbursed for their services. So you can take a private health insurance plan, and that reimburses a physician, let's just say $15. And Medicare, which tends to be the standard when we're talking about financing anyway, will reimburse the doctor $10. Medicaid, in comparison, often would reimburse it in this scenario as $5. And so it's somewhat of a charitable service, although on the back end for hospitals, they do pay a gap for how many people that they take for Medicaid, but a lot of, it's hard to find people that will cover you and take care of you if you have Medicaid. Next slide, please. So now that we have an understanding of these programs, let's talk a little bit, we'll talk a little bit more about how they play with different settings and how they play in different settings. So our earlier presenters have talked about the different areas. And so we'll start with assisted living. And now an assisted living residence or assisted living facility, which many times is called, is a housing facility for people with disabilities or adults that just don't want to live by themselves or cannot live by themselves. 44 states and DC pays for some of the costs related to assisted living. And different programs in Medicaid and the different structures will pay for different pieces. So we talk a little bit more, I know it was mentioned a little bit, but we'll flesh it out a little bit here. Home and community-based waivers is a special application of Medicaid rules that provide long-term care services within the state. And then there's state planned personal care and personal assistant programs, which is a standard Medicaid service. So Medicaid will actually come into your home, will pay for a CNA to come into your home and take care of you if you were able to qualify. So these are pieces that they will pay for. Medicaid does not pay for room and board, and coverage is inconsistent, again, across different states. Next slide. So to qualify for an HB, home and community-based waiver programs, this is usually what you're going to hear when you're looking for Medicaid. They have higher income limits for eligibility than your standard Medicaid, and their usually enrollment is capped. So for the District of Columbia, they have elderly and persons with disabilities waiver, which covers assisted living in limited situations. So you can use, again, Medicaid to cover your assisted living. And Maryland Medicaid will pay for assisted living under another program called Community Options Waiver. And Virginia does not pay for it at all. So again, you can see the variation within states. Next slide, please. So skilled nursing facility is, again, where one is discharged after a hospital stay. It helps with daily tasks during recovery or rehabilitation from a stroke, for example. And it's important to note the difference, which is skilled nursing facility as opposed to just a nursing facility or a nursing home. Medicare will pay for skilled nursing costs after, and these are qualifications to be able to get them to pay for you, a 3-day inpatient hospital stay, and then you are discharged immediately to the facility. I know I said this earlier, but Medicare will pay 100% for the first 60 days, and then 80% up to the next 100 days. And after the next 100 days, you are on your own. So if you have to stay in a skilled nursing facility for 135 days, you will be paying you'll be paying 35 days out of pocket. Medicare covers the short-term skilled nursing services, and Medicaid covers long-term nursing facility. So sometimes you will have those same services in the same facility, and different programs will pay for different things. So if you are living in a space where it's skilled nursing and then you need to kick off into long-term care, but you don't qualify for Medicaid, once again, you will be on the hook for that, even though you're in the same bed and you're in the same facility and you didn't do anything different. Again, a nursing home, and that's the difference, even if you're in the same facility, is where you live. This is where you reside. And then Medicaid will pay for that. Next slide. Look, we're time here. So long-term care insurance is something that you can use, and a number, we don't really talk about long-term care insurance enough. Long-term care insurance is private insurance that covers a lot of those pieces that Medicare and Medicaid won't cover. And they cover adult daycare. I know we've talked a little bit more about that. Like if you're living at home with your family, et cetera, and you need somewhere to go, and you go somewhere in the daytime, they will pay for those. They will pay for your nursing and assisted living facilities. They pay for your in-home services as well. And it works, again, a lot like your employer sponsored healthcare. So if you're really, really sick and you're trying to get healthcare insurance on your own, it's going to be hard to obtain it. So you don't want to wait to get this kind of insurance when you are ill, because it'll be hard for you to get coverage. We spoke a little bit earlier about PACE. And so the PACE program provides comprehensive services and social services to frail elderly people still living in the community. So you are meeting the level of a nursing home, but we want you to stay in the community. And unlike the government, unlike the way it's administered from the state and the federal government or from a health insurance, this is a group that comes together like an organization that is a non-for-profit that provides these services. Medicare and Medicaid will put together a what we call a capitated rate or a per person rate to be able to pay for these services. And I think Dr. Karoma Nelson spoke about how they will follow you around. And then basically the idea is you are within this community and they take care of all of your services along the continuum of care. Next slide, please. Again, to be eligible for PACE, you have to be 55 or older. As you notice, that's a 10-year decrease in eligibility, in age eligibility. You have to live in the service area of a PACE organization. And again, that's similar to a network, but even smaller. So you have to be close to a PACE organization. It has to be certified. The organization has to be certified by the state as eligible for nursing home care. And you have to live in the community. So you can't be in the nursing home, but they have to be able to be certified to provide these services. You have to be able to live there safely. So you can't need nursing home level skills provided for you, and you just say you're not going to go. That's not going to work either. You have to be able to live there safely. And you have to receive all of your care exclusively through PACE. So you can't be also, deciding I'm going to go off to one doctor or not. You have to sign all of your care to this particular organization. It's based on the way that they're paid and being able to balance your quality of care. They're checked on that too. So you can't go outside of network. You can't see anyone else. So that's quite limiting. Next slide, please. Before I get into that, one of the pieces that's missing or that's important to talk about is the continuing care retirement communities. And so that's a community that cares for you along the lines of the continuum of care. So even if you're a well-bodied or well-abled 65 and up individual, you may only need a little bit of assistance. You may now need skilled nursing. You may need something related to nursing home. It's all provided in one place. So you can sign up when you're thinking 65 and you sign a contract and you just pay per month. And say you have something happen to you, your monthly payment doesn't go up. So sometimes it's called a maintenance fee and other times it works as rent. And you may see them around. I think one of the examples is Dr. Karoma Nelson's facility. The Goodwin House works just like that. So it seems like a nursing home. It looks like a, assisted living, and you see all types of able individuals, functioning individuals in that facility. So anytime I give a talk like this, I get standard questions, and they are, how do I know if I'm eligible? It seems really intricate. I've heard of spending down. Spending down always seems like a very touchy topic. People aren't familiar with it. And what about young disabled individuals? I know disabled individuals are on Medicare and they don't have to be older. So I'll talk to you a bit about some of those things and give you some examples. And hopefully through these examples or cases, some of these questions will be answered. So spending down is a financial strategy when it comes to a person's income. So if your income is too high for Medicaid, you can have a lot of expenses that makes you meet a certain criteria. And that certain criteria is called medically needy. And it differs from state to state, again, for the influences that I spoke about earlier. But to be able to spend down, you have to show that the excess of your income is medically related, excess of your income over the limit of Medicaid. And when you're able to show that, Medicaid will start to kick in if you are deemed medically needy. So for an example, you have a mother of 3 who has an income of $950. And the limit for Medicaid for a person is $794. So first, her children, because the income limits for children is a whole other thing, their kids will have Medicaid, but you have to worry about herself. If she spends the excess of the $794 on medical services, and she's able to prove that this is where my excess of my income is going, she will be deemed medically needy. And for 6 months, because we're using Maryland as an example, eligibility is for 6 months. And so for those 6 months, Medicaid will take care of her. And then she has to prove that again for the next 6 months. So I'll give you another example of a married couple. If we, next slide. Of a married couple who also has a similar situation of $1,901 of income, a month in income. That's the limit. So say they have $2,000 in income. They have to show that they are medically needy, and the limit is $3,000. Hold on. It's $3,000 for a married couple. So they have to show that they make less than that. What's important to know is what counts as income. So Social Security income, supplemental Social Security income, is different than what you see taken out of your check, which is SSA. That's for disability, and that's for age, and that's an entitlement. SSI, which is again different, is a needs-based function. And so you have to show that you also have you're disabled, or you're legally blind, et cetera, and you are low income, you get this as income. So anything that is that's taxable, any taxable income counts as income. So you're talking about your 401ks, Social Security, but not SSI. So including SSI, once you get SSI, you're automatically anywhere eligible for Medicaid. That being said, you are counting all of these different myriads of income to see if you can qualify to be medically needy. 2 things: in different states, one person, if you're applying as a married couple, can apply individually, and in other states you can apply as a couple. And if you're applying as a couple, you have a certain couple income limit, which we have here is $3,000. But in another state, you can apply as an individual and still have a married person, and that person not actually have their income included at all. And certain states, again, different states, certain states have limits on what that can be, and other states have no limits at all. So it's really intricate on how to plan for retirement, because you would tend to need a financial planner to see who you can shift some of your assets to, and shift, and what assets you have to be able to keep, or that you can keep. Now, there are certain things that are countable and not countable. Mostly, you don't have to count your home. You don't have to count one car. You are limited to $2,000 worth of cash on hand. But when you start thinking about the resources that you have to not have, that's countable, you're talking about your mutual funds, you're talking about trust payments, et cetera. But again, learning what's intricate, you have to know, deal with a financial planner to be able to know how you can play against the rules in different states, which is expected for your long-term planning. In Maryland, Medicaid and Medicare will pay for, well, Medicaid will pay for certain modifications of your home. So that's actually something I did want to bring up. So even if you're working and you're living in the community and you want to do some of this yourself, Medicaid will pay for you to modify your home. So you're talking about your what is the thing that takes you up the stairs, the railings in your bathroom, you can get if you qualify, Medicaid will pay for those things. Next slide, please. So, okay, we've talked about a lot of things. We've talked about your income, we've talked about your assets, we've talked about spending down. We also have to talk about needing and getting extra help. Just a few pieces around caregiving. Caregiver support and having those flexibilities and payments is really, really important. And certain states will reimburse you as a caregiver. Some states you have to qualify, get your own CNA license, and they will know that you're a family member and they still will pay you. They have services that are reimbursable under Medicaid for caregivers for their own counseling, their own screenings, their own situations of the sort. And if you are in a self-directed Medicaid services program, they also allow for greater flexibilities and will reimburse you for your driving, et cetera. So I think I stressed here how financial advisors are very important in strategizing how you're going to live long-term and managing your assets. And so these are really important resources to take advantage of. And I think that's the end. Thank you very much. Next slide. Thank you very much. If you have any questions, definitely reach out to me, but here are the resources that are really important. You'll get so much information on Medicare.gov, Medicaid.gov, and most importantly, please visit your Medicaid your state's Medicaid website. That is where you're going to find all of the things that you are eligible for and covered services for your enrollees and caregivers. AARP gives a number of resources around how to plan, what that looks like. Senior living and caregiver.com is very important. My email is on the next slide, and that is chinonya.onwanley@gmail.com. And I'm happy to answer any questions that you have, anything you would want to dig into. Please feel free to reach out.
Thank you. Thank you. Thank you so much, Ms. Onwuli. Wow, what a great presentation from all our panelists. Ms. Onwuli, I'll let you know there are lots and lots of questions that are being asked. I mean, the live chat was just going off and I'm like, oh my God, we need so much more time to answer all these questions. So I would not delay. And I think some of the questions you've addressed them in your presentation. So the first question is, can a resident of another state get care with Medicare coverage if visiting another state? I think you mentioned that earlier, that if someone is living in Maryland, for example, and visiting Texas with the Medicare Advantage versus the Medigap, will they be able to access Medicare services, medical services in another state?
And see, that's exactly the piece that so did they say Medicare or did they say Medicaid? If they are
Medicare.
Okay, if they have Medicare, yes. If they have Medicare, they should be able to receive, and they have Part A, they have Part B, you can go wherever you want. But if you're on Medicare Advantage, you have to stay wherever your network is. Now, of course, the network could be large. If you're in Blue Cross Blue Shield, they have different networks and it's really large. But if not, that's where you have to stay, or you're paying out of pocket, or whatever those stipulations are in your plan.
Okay. Thank you very much for that question. A few people, go ahead.
But with Medigap, you do not have that problem.
Okay. A few people did ask, if let me see another one here. Say if they were a millionaire and they have enough funds for to retire or in their retirement fund, can they still or should they still apply for Medicare and or Medicaid? And is that the same thing as Medigap?
So no, that is not the same thing as Medigap. Once you retire, you are automatically qualified for Medicare. If you get on Medicare Part A, if you get on Medicare Part B, they have a sliding scale past a certain amount. So if you are a millionaire, you're going to have to pay way higher premiums than someone that's less. And so it may be within your in your best interest to just go on ahead and buy a private plan for yourself and not necessarily have to pay for Medicare. So because you're going to be paying a premium for making a lot of money.
Okay, thank you very much. And another question here says, assuming one spouse gets into retirement age much earlier, does your spouse's income affect your Medicare and Medicaid coverage? For whatever reason that a spouse has to retire, whether it's due to a disability or a health issue, whatever, would the spouse who's still working, would their income affect Medicare and Medicaid application? Or
so for Medicare, it doesn't apply. Unless you're a millionaire and you will both have to pay that high premium for being a millionaire on Medicare. However, it doesn't affect it's an entitlement program. So once you're 65 or you're disabled and you qualify for Medicare, you qualify for Medicare. Your spouse, if the spouse is 55 and hasn't reached the age, they do not qualify for Medicare. Now that's the difference. It's totally different on Medicaid. And again, that varies across states, but for the most part, if you are applying and you are married and that state counts as a married couple and your income is too high, that person doesn't get Medicaid. But if you are in a state which it will allow one person to apply as a single person, and that person doesn't have any assets and that person doesn't have any, extreme resources, and by themselves they would be poor, they will allow, based on the spending down rules, they will allow that person to get on Medicaid. Okay.
And the last question that I would ask, again, so tons of questions here, I would say, owning a property one lives in can co-owning a property one lives in count against an individual in being eligible for Medicaid plan under the spending down?
Co-owning the place that the person lives in. So your house counts as an asset that's not countable, if you will. So they will allow you to own your own home. They will count as an asset a vacation home. So or a rental property. So if you co-own a rental property, that's going to count.
Okay. And someone also said here, please clarify that one needs to have contributed enough or have enough quarters to be eligible for Medicare at retirement. Can you speak to that briefly?
Yes. Ooh. Okay. So if you had been a non-working spouse and you decided to start working towards the end, and you have to have a certain amount, and I'm missing the number of quarters in my mind because I tend to know a lot more about Medicaid. I'm missing the number of quarters in my mind, but there is a certain amount of time that you have to pay into Medicare to be able to be a recipient. So it's tough when, we think of our parents, again, in the Nigerian or African immigrant community, and we want to bring them over and they work a little bit and they aren't able to be eligible, or they're 65 and they aren't eligible for Medicare, even though they have their citizenship now, et cetera. It's because they weren't able to work. They didn't put enough into the Medicare coffers. So again, you're looking at your check, you're looking at Social Security. As long as you're paying a certain amount, there's a certain amount that you have to pay in to allow you to be eligible to receive. And so that's, again, the difference for Medicare, but that's not the case for Medicaid. You can come here, get your citizenship and not make enough money and be on Medicaid.
Thank you so much, Ms. Onwuli, for answering our questions. A question just got snuck in. I know we are pressed for time. Can a non-US citizen apply for Medicare or Medicaid? That'll be the last question.
So the short answer is no. I mean, so if you are a non-US citizen, but you have been paying into it, and you have a certain amount of quarters to pay into Medicare, yes, you can get it. You have to be a US resident or a citizen, but you many places, and again, it's different, different political influences. Mostly you have to be a citizen, definitely in Virginia, you have to be a citizen to receive Medicaid. In a lot of places, a citizen, they're not trying to pay for immigrant on their rolls. But sometimes you can, but no, most of the time, no, not at all.
Okay.
Mhm.
Thank you so much. I wish like we could go for another hour asking all our panelists, Dr. Kuruma Nelson, Dr. Fakia, Ms. Onwuli. Thank you guys so very much for honoring our invitation at Rapha Health and Fitness Ministry, for taking your time, your precious time to answer all our questions and providing all this information. Viewers, listeners, I did say that you were going to get a wealth of information, and you know, this our YouTube channel is always here. If you've watched and you feel like, oh my God, I missed one or two things that was said earlier, feel free to click that watch button again and watch it over and over again. Share with a lot of your friends and family, because I know someone or 2 or 3 or 10 people or more will benefit from today's seminar. Listen, like I said, I wish that we could go on and on, but I would like to thank a few people that have made today's seminar so successful. First of all, I want to thank Pastor Gandhi, who is our senior pastor at Jesus House DC, for giving Rapha Health and Fitness Ministry the platform to always reach hundreds, if not thousands of people worldwide to pass this message of love, care, and support to them. I also want to thank Dr. Olumide Ogunjuyigbe for his continual service and support. He's our minister in charge at Rapha Health and Fitness. He's always supportive. We thank you very much and we appreciate you, sir. I cannot forget our head of department, Dr. Disola Ogun Shemowo. Thank you also for your relentless, exemplary leadership skills, how you support every team member at Rapha Health and Fitness Ministry. I do also want to thank Dr. Mercy Lugutera, our program lead, for coordinating this seminar. I'm telling you, it could not have been this successful without Dr. Mercy coordinating from the idea phase to the execution phase. We thank you so much. Dr. O, thank you so much for editing the PowerPoint and making it such a smooth transition between our panelists. I want to thank every member of the Rapha Health and Fitness Ministry for the back end work that you've all been doing. Thank you so much for always holding each other's hands and supporting us through spiritually, physically, emotionally, in all ramifications. Last but not least, I do want to thank our listeners. We could have put all this together, but if you didn't show up today, then we would have just been talking to ourselves. So we want to thank you for tuning in today, for listening, for asking all these questions. If you have any additional questions, please feel free to reach out to the Rapha Health and Fitness Ministry Department. We will definitely answer those questions and get back to you. To everyone who who was not part of this live session, who will be watching this later on, we encourage you to also ask your questions and reach out to Jesus House DC Ministry at large to ask your questions, and your questions will be directed to Rapha Health Ministry. Thank you so much, everyone. Thank you to all our panelists one more time, Dr. Kuruma Nelson, Dr. Fakia, Ms. Onwuli. Thank you for your support. And until next time, please be on the lookout. We have so many more programs, not only as Rapha Health and Fitness Ministry, but Jesus House DC. We always have multiple programs that are sure to enrich your life. So be on the lookout for our next announcement, our next flyer, our next program. Until next time, have a wonderful day. My name again is Latunde Bolarinwa. God bless.